Good morning, ladies and gentlemen. I'm David Taggart from Oxford. My co-chairmen are Professor Pepper, Mr. Tony D'Souza from the Brompton. We're going to talk about various aspects of coronary artery disease today. And it is worth bearing in mind that despite all the other advances going on in cardiothoracic surgery just now, that 60% of most adult cardiac operations are still coronary artery bypass grafting. And indeed, if you look throughout the world, figures from Medistim show that there were 750,000 cabbages done throughout the world last year, so 750,000. So this is still a big operation. And today we're going to explore several aspects of perhaps the best way of doing it when it's indicated. We're also going to talk about the importance of ischemia. Now, unfortunately, outside there are still long queues at the desk. I don't think most people are going to be registered till 9:30, but the program is tight, so I'm afraid we're just going to have to crack on. And in that case, I'm going to introduce the first speaker, who's Dr. Mark Dweck, who's a non-invasive consultant cardiologist. And we're going to start this session this morning by exploring the preferred treatment for LAD disease. Mark, thanks.
Okay. So that looks like your talk.
You want to give my talk?
Not sure I can. Have we got my slides? My case presentation slides.
Okay, while we're waiting for these slides to come up, let me ask this small select audience. If you personally had isolated proximal LAD disease, I'm going to ask the question, who would prefer to have a stent, a drug-eluting stent put in that disease, and who would prefer to have a mammary artery? So you have isolated proximal LAD disease, you've demonstrated a significant volume of ischemia, so you know that you require some intervention rather than just optimal medical therapy. Who would opt for a stent and who would opt for internal mammary artery? So if you would opt for a stent, please raise your hand.
Was it on your side?
Sorry?
Yes, on you.
Yeah. So
Not your mother.
about half, who would opt for an internal mammary artery? So I'd say it's probably 50-50.
50-50.
So?
The slides up there. You can do it.
We've got
Thank
slides, yeah. So, so good morning. I'm Mark Dweck. I'm a lecturer here in Edinburgh. And my disclosure really is just that I'm not a cardiothoracic surgeon. I'm a cardiologist. And I guess what's the difference between us? Well, we as cardiologists perhaps at least pretend to know how to use a stethoscope. But I'm not an interventional cardiologist, so I don't have a bias here really. I'm just want what's best for our patients when trying to pick between PCI and bypass. This is a patient who we saw just this week actually. So he's 62 years old. He's male. He's an ex-smoker. And he gives a 4-month history of exertional chest pain. Typical angina, there's not really anything that you would argue about that. His examination, as usual, is unremarkable. His ECG is unremarkable. And he gets seen in the rapid access chest pain clinic and gets put on the treadmill. And he manages 5 minutes before developing his chest discomfort and ST depression in a fairly kind of widespread distribution. He has an echocardiogram that shows that he has good left ventricular systolic function. He has no significant valve disease. He has normal renal function and his hemoglobin is 1T7. So he goes on to have this angiogram, and it's fairly subtle on this, but he has an ostial lesion in his LAD. So this was the operators performed an FFR, and indeed his FFR showed that this was functionally significant. And he was discussed with the cardiothoracic surgeon on call at the time because it was felt that this was procedure in terms of stenting, you'd have to be leaving the stent right on the ostium of that large LAD vessel. So the discussion was had, this is his only disease, and the discussion was had about the optimum revascularization strategy. And we thought the options were a formal bypass operation, perhaps a minimally invasive bypass to the LAD, PCI with insertion of a stent, or there's always medical therapy. So I'm going to leave that there, and we'll have a look a bit later on about what actually happened to that patient. Okay, thanks.
Thank you, Mark. So our next two talks are going to be whether surgery or PCI is the preferred option. And we're going to start with Professor Günther Lauter from Vienna, who's going to tell us why surgery is preferred.
David, thank you very much. Thank you for the invitation to discuss this particular case. Of course, may I have my slides, please? I would opt for a minimal invasive bypass procedure, preferably for a mid-cap operation, but you can also select in the few centers where there's extensive experience a robotic assisted Lima to LAD, either on pump or off pump.
Excuse me, can we have the correct slides, please?
These are not my slides. So just before the slides arrive, just to give you a brief background, I come from the Medical University of Vienna, and no.
Try again.
That's the wrong set of slides. We just follow the program.
So it's a really randomized session, I think.
Yes, so it is.
The ultimate goal in medicine.
We live in the world of randomization.
The ultimate goal in medicine is achieved
and the uncertainty
already in the
principle,
morning.
Yeah.
Okay, thank you very much. So the answer is already given. Surgery is preferred. And just to give you a little bit of my background, this is the Vienna General Hospital in association with the Vienna Medical University. It's one of the largest hospitals in the world, and it's comprises about 2,230 beds. So if we want to give the evidence on proximal LAD cabbage versus stent intervention, there are only a few prospective randomized trials, and these trials suffer from the disadvantage that the number of patients included in these trials are rather low. So meta-analysis is one way to get more knowledge, to get more information on this particular topic, and there are two meta-analyses. I have shown you the first one already in the previous slide that comprises about 12 studies, and out of these 12 studies, 6 have been prospective randomized, the others have been observational studies. As you see, there are 3 clear advantages in favor of bypass surgery, and this is the incidence of repeat revascularization at the latest follow-up. This is the recurrence of angina, or the freedom from angina, which is clearly in the meta-analysis in favor of bypass surgery. So these are 2 parameters of quality of life. And there is, if you look on the major adverse cardiac and cerebral events, there is also a clear advantage in favor of bypass surgery for the Lima, for the proximal LAD, mainly because the last outcome, the MACE outcome, is driven by repeat revascularizations. There's another study, another meta-analysis that also comprises that only comprises prospective randomized controlled trials, and what you see here is the same freedom from repeat revascularization after 1 year as well as after 5 years is clearly in favor of bypass surgery. We have to note that from all the available evidence and from the maximum follow-up of 5 years, there's no more follow-up beyond 5 years. So I would name these midterm results. They are significantly less MACE or either cerebral and cardiac or only cardiac events. In the bypass surgery group, there is significantly less repeated revascularization, and there is significant better freedom from angina. There's the difference in survival, MI and stroke, could not be demonstrated within this meta-analysis or any individual study. And certainly I will foresee the argument of the interventional cardiologists that we will have improvements in the next period by a never-ending generation of new stents. And I remember the early days when the bare metal stents came up, and the bare metal stents were compared versus simple PCI. We have been told as surgeons that these are already dropping the risk of re-stenosis to 10 to 15%. Then the drug-eluting stent emerged, and in the first studies comparing drug-eluting stents versus bare metal stents, there was also an absolute risk reduction of 10%. And that also was the case with the following studies of the second and the newest generations of drug-eluting stent. So theoretically, the stent improvement or the improvement in stent therapy would mean that we have a restenosis rate of minus 20% or minus 25% already, or a patency rate of about 120 or 125%. I'm sorry to say that, but this is certainly one argument that has to be taken into account when we discuss this case. So what are the methodological restrictions comparing PCI versus CABG? We have in all these studies a small sample size, and the small sample size means that even if there was an effect, we could not have been detected the effect of, for example, 10% difference, because the sample size of 100 or 150 cases in the cells, and the largest one was that from Digeler with 200 cases, was too small to detect the difference. So then there is an unblinded character of the outcome assessment in these randomized controlled trials of CABG versus PCI. And we have always the sponsor bias that favors PCI. For example, in some studies, only interventionalists are authors, either on the advisory boards, and these interventionalists are either on the advisory board or consultants of medical device companies, like, for example, for the CIMA study. That was a study that was run in Switzerland. And furthermore, important adjunctive medications are underutilized, still underutilized in the bypass population. And we have not to forget the background of advances for both PCI, not new stent generations, but also there are new developments in the CABG arm. But now this is, I think, the strongest argument I have to bring forward to you is the real long-term, not the intermediate-term survival. And you see, the red square starts at the point where in this study that was published from the Cleveland Clinic in patients who received between 1971 and 1973 an isolated lemur to the LAD or a vein graft to the LAD. And they were followed for 20 years, for almost 20 years completely, and the study was published 21 years later, after the last patient was operated. And you see the start of the red square. After 5 years, this is the follow-up time point where the follow-up of all the stent trials for a stent to the proximal LAD is ending. And there is no difference between vein grafts on the LAD, and there is no difference with lemur to LAD, and no difference to the general US, the matched age and gender matched US population. If you follow now up to 10 years, there's still no difference between lemur and the vein grafts, but after 10 years, the curves tend to separate, and we find something which is very specific and is very unique in medicine, that you can prolong life with an intervention, and the intervention is the isolated lemur to the LAD, and after 20 years, this intervention offers better survival than the general survival of the age, as I said already, as the age and sex-matched population. This can also be attended to another group which is observed in triple vessel disease, and you see here, after 5 years, there is still not too much difference between the lemur to the LAD and the vein graft. I have to stress the point that this is the setting of triple vessel disease for patients with preserved left ventricular ejection fraction, but after 5 years, these curves diverge, and this is something which certainly will be seen in the next future. So my conclusion is the LIMA to LAD is the best treatment for symptomatic proximal LAD disease, and the LIMA is the better coronary. Thank you very much.
Thank you. Now we're going to have a counter presentation that PCI is the preferred treatment by Professor C Hamm from Bad Nauheim in Germany.
Yes, David, thank you very much. I'm not having a presentation to make it easy, so no slides from my side, because I think we just discussed this case here. And the facts have been presented more or less. And I think I want to stick with the case, and the case is not easy. It's an osteal lesion of the LAD. LAD is not LAD. If it's an isolated lesion away from the main stem, I think it's a different issue. But here it's an osteal lesion, which is somewhat challenging for an interventional cardiologist because I would have stented this into the main stem. But we know from syntax that PCI is doing at least as good as surgery in these cases. So I think it's a fair option to have PCI in this patient. I see the problem in the patient, to get informed consent from the patient, because in my daily life, when I talk to the patient, I give him the option. I say, okay, maybe you should have surgery, but PCI may be an option. Then most of the patient will say, yeah, what is better? And I say, I really don't know. You get home earlier if you have PCI, your long-term result may be better if you have surgery. Then most patients will respond, okay, let's have PCI first. I say, there's nothing like first, but I never had a patient that said, let's have surgery first. And so the problem here for the decision is the patient, because the patient is the one, and I think the patient should be heard about this. And at the very end, you have to leave it to the patient. And to be fair, I think both are good options. And if my patient responds, no, I want to have really, I'm 60 years old, as this patient was, and probably have to live another 30 years. I want to have really a good solution for the next 30 years. I would not mind to send the patient to surgery. But this is rather rare. The patient, at least in my environment, will say, let's have PCI first and then see how it works out. Because this can be done, has to be an experienced interventional cardiologist to do this case, but it can be done safely and also probably with a good outcome. So that would be my answer to this.
Thank you very much, and thanks for keeping to time. So we're actually moving ahead of the program just now, which is excellent. And our next speaker is Professor Philippe Kohl from Liege in Belgium. He is very well known as being one of the senior authors of many of the guidelines on myocardial revascularization, both for ESC and EX. And he's therefore going to tell us what do the guidelines say.
Thank you very much, and thank you for inviting me to the session and to the SCTS University. So what I will here do is discuss mainly what we said in the guidelines developed 3.5 years ago. You may know that we are doing a new version of the guideline that will be released sometime this year, certainly at ESC and maybe already at PCR. What is interesting about these guidelines, the 2010 guidelines and the new one, is that, in my opinion, they are joint guidelines. They are the guidelines developed by a group of colleagues who are cardiologists, interventional and non-interventional cardiologists, and cardiac surgeons. So typically a case like that, obviously, we have discussion. I mean, we don't discuss every single anatomy, but I think that's important to emphasize. So very briefly, I would like to address 4 points: revascularization ad hoc versus at an interval, heart team discussion, indications for revascularization, and the technique. The first point is revascularization ad hoc versus at an interval. When a patient like that is on the cath table, I think the most important thing we are discussing here about a stable case. We are not discussing about a stable was an acute event. If this patient was having a STEMI or a non-STEMI with a high Gray score, there is no question that he should be treated rather immediately. In this case, I think he needs time to think and time for discussion. And that's the reason why in the previous guidelines we made a distinction between potential indication for ad hoc PCI, meaning to treat immediately while the patient is still on the cath table, versus revascularization at an interval. Patient go back to bed, to his room, and he has some time to discuss with himself, with his family, with the GP, with other doctors. And I think in a case like that, that's precisely what should be done. So what we say here is that ad hoc PCI should be done for hemodynamically unstable patient and culprit lesion in acute events, stable low risk with single or double vessel disease, proximal LAD excluded, and favorable morphology for the mid or distal LAD, non-ostial circ or RCA, and non-recurrent stenotic lesion. And we acknowledge that ad hoc PCI is convenient for the patient, associated with fewer access site complications and often cost-effective. It is therefore reasonable for many patients, not for all, and is certainly not should be applied as a default approach. On the other end of the spectrum, we listed as potential indication for revascularization at an interval the following indication, and they do include stable patient with ostial or complex proximal LAD. So I think, in my opinion, a case like this should be discussed and not treated immediately ad hoc. Now, what about hospital teams without a cardiac surgical unit or with interventional cardiologist working in an ambulatory setting? Well, they should refer to evidence-based protocols designed in collaboration with an expert interventional cardiologist or cardiac surgeon, and possibly seek their opinion for complex cases. The second, and it's comes very naturally from the first topic, is this case should be discussed within the heart team. And I strongly believe that. As I think both of my colleagues said, this case can be treated by PCI if it's an experienced interventional cardiologist and if the patient understands the benefits and the potential weaknesses of this technique, and the same for CABG. So what we say in the guideline is that the patient should be placed at the center of the discussion, not any other particular consideration, such as, the hospital needs more patients in this particular technique, or we need shorter or longer length of stay, or whatever, or have some kind of a big ego. The patient is at the center, should be discussed by the heart team, and this heart team should probably include the referring cardiologist, the interventional cardiologist, and the cardiac surgeon. And actually, the task force developing these guidelines is a balance of subspecialties. The third point is, we could actually start with that, does this patient need indication as an indication for revascularization? The answer is yes. Why? We didn't see it, but most likely, I guess it was done, FFR was calculated, or he had another positive stress test. So there is an indication for revascularization, which is ischemia. And what you can see here in this indication is the importance of ischemia, and each time you see an asterisk, that's the demonstration of an ischemia. So we don't treat an anatomic lesion, we need to treat a functional lesion that will create ischemia, in this case a proximal LAD greater than 50%. So it means angiographic diameter stenosis 50 to 90% with fractional flow reserve below 0.80, or documented ischemia with former techniques. You can also proceed with revascularization for symptoms, in this case limiting angina, but here it is more important. There is an indication for prognosis, proximal LAD more than 50%, and it's a 1A, okay? So revascularization here is recommended. And the last question is, which technique, PCI or CABG? So we'll see what the next guideline said. As I said, they will be released sometime this year. So in this table, what we did is to put most anatomical possibilities according to 1, 2, 3 vessel disease, the syntax score, first, second, and third tertile, and left main isolated or associated with other distal disease. You have to carefully read the title of this table. Indications for CABG versus PCI in stable patient with lesions suitable for both procedures and low predicted surgical mortality. That's important because some people say, well, you sometimes do PCI for even the last line or for 3-vessel complex LAD. Yes, but not with low surgical mortality. You should not. So where are we here? We are 1-vessel disease, proximal LAD. CABG is recommended and PCI should be considered. 1A, you can argue that it could be 1A or 1B, but it's 1 in terms of is recommended. But PCI should be considered. So both can be considered in the same patient, and they certainly should be discussed within the heart team. So that's my conclusion. This patient should be discussed with the heart team. The patient should have enough time to think, not 5 minutes. And we should make sure that he or she understands what are the advantages of PCI, the advantages of CABG, and the disadvantages of either techniques. Thank you very much.
Thank you very much, Philippe. So before we come to find out what actually happened to this patient, we're actually about 10 minutes ahead of schedule, so there's a little bit of time for discussion. And I'd like to open this first by asking everyone in the room, who works in an environment where there is a regular, so I mean a formal MDT meeting at least once or twice a week? So the majority of people do. And who works in a unit where that does not happen as a formal exercise? No, just one person, okay, fine. So the second thing I'm now going to ask, before we find out what happened to this patient, so to summarize, we've got a 64-year-old with no other significant comorbidity who has isolated osteal LAD disease and the assumption of ischemia with a positive exercise test. So the options we have for this patient are do nothing, optimal medical therapy alone, optimal medical therapy with a stent, or optimal medical therapy with an internal mammary artery. So 4 options: nothing, optimal medical therapy alone, optimal medical therapy with stenting, or optimal medical therapy with CABG. So who would go for do nothing? Good. Who would go for optimal medical therapy alone? Nobody. Who would go for optimal medical therapy with a stent? Remember, this is a surgical audience, so don't get too worried. So there's maybe only 4 or 5 people. And who would go for an optimal medical therapy with an IMA graft, assuming the patient was happy? Right. So not surprisingly, there's here a clear view that the best treatment for this patient we would recommend would be optimal medical therapy plus an IMA graft. And before, again, we come to what happened to this patient, one of the things that's very important to remember when you look at these randomized trials of internal mammary artery versus stenting for proximal LAD disease, what none of those trials tell us is how many patients with proximal LAD disease were excluded from the trials because they had disease that was too complex for treatment by PCI. Those figures are never presented. So we're seeing already a skewed population. And the other thing, and we'll talk about this this afternoon, is the other thing the patient should be told is the prognostic benefit of a mammary artery out to 3 decades of follow-up. Now, we do not have that information for stents. Most of the stent studies, as Professor Laufer made the point, are relatively short-term follow-up. So these are 2 important considerations that the patient should be made aware of before they decide what therapy they want. So in the next 5 minutes before we come to what happened to this patient, any questions or comments from the audience?
I have a question. To some extent, this is a slightly idealistic patient. I mean, there is no comorbidity whatsoever. So I just want to ask you, if this patient had an above-knee amputation on one side, would your recommendations alter at all? Well, the majority of you believe that this patient should have a Lima to LAD.
Yeah, award would be the patient with the above knee amputation. That's what I'm asking for. 50,
Yes.
60?
How?
Sorry, how old? Oh, same age, same age.
Young.
Well, 62, isn't he, the patient? Is that
64. I think.
60, well,
Rather young.
yes. Yes, he's not 84. So I just wondered if that would alter anyone's decision.
Depends on the cause of the amputation. One is traumatic.
No, the amputation is for peripheral arterial disease. He's a smoker.
Is he still smoking?
No, he stopped smoking after his amputation.
Vipin?
Which was
I'm just trying to get the thing a little bit more down to earth, the kind of cases we actually see.
I think this particular patient, if you add a few more comorbidities, if he was obese and had COPD, I'm sure the majority of surgeons would say give stent a try, and then let's see what happens.
the thing if in a patient like with more risk, unless
Yes.
it's really prohibitive, the likelihood, I don't know, Chris, the likelihood of early failure of the stent, isn't it increased if he has more comorbidities or not?
If he's diabetic, I
Diabetic.
think that's a critical thing. I would really
I was about to add that.
Okay.
I don't care about other comorbidities, but it's diabetic. I would very much agree if he says, okay, I want surgery. Because not so much of the lesion of the LED, because I'm afraid of progression of disease and other arteries in the next 20 years. And then what is still LED.
Mark, did you have a comment?
Well, I'll make a comment perhaps when I do, but I think if you've got more comorbidities, then my eyes that would swing you more towards bypass because you've got a higher risk of future events and therefore more potential benefit from the bypass versus the PCI.
I think it's a balance between the risk associated with the Euroscore 2, the STS score, which normally you will capture according to the age and the comorbidities of the patient, the long risk benefit, and what the patient wants or wishes.
Professor Lodge?
Yeah, I think if the patient has more comorbidities, one should really consider to do a mid-cap surgery. However, mid-cap is a procedure that has been shown to cause problems in sites where the surgeons don't really know how to do it. Unfortunately, the hype of mid-cap surgery is over, and mid-cap is performed usually now only by surgeons that know how to do it. So for me, the most important thing would be if I'm a cardiologist or if I'm a patient who has to undergo Lima to LAD with a small left anterolateral thoracotomy to know who is doing the surgery and what are his results. And I think that's the surgery with this type of approach is much more the result much more operator specific. Although I think PCI is also not an easy procedure, it cannot be done everywhere in small community with not too much experience. But I think that's also a very important thing to realize as compared to open chest, on pump, Lima to LAD on the rest.
Thank you.
There's a question there.
Sorry, please. Yeah. Prasad, hi.
If this evidence suggests it's class 1A, then do we still go by the presence of other factors?
No, I think that should be part of the discussion you have with the patient, which is that a group of European experts recommend that the best treatment for this is an internal mammary artery to the LAD, but that same group also recommends that you can consider doing a stent.
David. But David, I mean, we heard that patient choice is driven and is often one of the excuses given by cardiologists. But one of the problems is the cardiologists don't always inform the patient in a fair manner, because I think if the patient did see a surgeon and a cardiologist at separate consultations, you will find that both of them will be sold a different prospect of what the outcome was. I mean, the example, as you said, most patients, if given an equal poise for surgery or PCI, would be silly to take surgery. Whereas if they were told it's a class 1A evidence for surgery, then they would consider it and probably accept it.
I mean, and this is absolutely crucial because patient perceptions are everything. What they think they've heard, what they think they know. About 3 years ago, I had a private patient sent to me for a single internal mammary to the left anterior descending. And he was quite a demanding patient, so it took 15, 20 minutes to discuss the pros and cons of this operation. And at the end of it, he said, I've one final question. Can you do this minimally invasively? And I said, yes. And I walked over to him and I said, all I'm going to do is open you from here to here. And he said, that's fantastic. So he was happy, yeah. It's all the perception. And the point is, it depends how you explain and tell patients. We know we can get a patient to do anything, even on the faintest nuances of how we present things to them. On that point, we are going to now hear in the last 5 minutes what happened to this patient.
So I'm afraid there's a few slides.
Can we get the last?
Okay, so what happened next? So we're all familiar with the story by now and discussed it at length. The decision, I have to add that I wasn't part of this decision, so I want to make it out of the room alive. But I'm not the culprit, but this is the patient's angiogram to remind you. So an ostial LAD lesion that we know is significant. He's had an FFR to that lesion. And after discussion, I have to say, after discussion with the surgeon, the decision was made to go ahead with PCI. And so this is the procedure here. You can see the wire down the LAD. It's pretty tight, isn't it? And they've positioned the markers of the stent right at the ostium and gone ahead with the procedure and actually got a fantastic result. So that was the outcome of the study. The patient's lesion was treated and their ischemia was relieved effectively, at least in the short term. So we can argue about the long-term implications of that, but that's what happened in this particular case. Okay.
How long ago was it?
This case was actually 2 weeks ago.
So that's a long-term outcome.
He's doing very well. Yeah. Well, I think that was one thing I wanted to add, that if you want to impact on outcomes, then probably the most effective way to do that is optimum medical therapy. We shouldn't forget that in our discussions of deciding between PCI and bypass surgery.